No, I work as a consultant in pain management at Guy's St Thomas's. Most of my work is adult-based, but I see children and I run a children's clinic twice a month, both myself and as well as a joint multidisciplinary clinic with the pediatric rheumatologist. And now I'm going to talk a little bit about interventions in children. Now, this isn't something that you'll see commonly. If anything, it's quite rare, and it's quite a niche subject, so you're not going to see high-grade levels of evidence. But what I want to do is to give you a little taste of what really can be done. I know a lot of pain medicine in children tends to be based on the rehabilitation side, but I'll give you a few examples on what we do as pain doctors and the skills that we can find quite useful. So this is where the Children's Hospital is based, at the Everleigh Children's Hospital, right next to St Thomas's. So it's about 15 years old now. Lots of glass, so in the summer it gets a bit hot. Now, this is an example of a girl that has been known to me for a few years. So she has, as you can see, quite, well, not massive scoliosis, but she's got back pain. And she's completed a number of different programs, physio, cognitive behavioral therapy. She's tried medications. And the big struggle is that she's struggling to get to school. And the thing is, it's not like the adults where, yes, you can get a few days off. She's got her exams coming. And her pain, interestingly, isn't in the thoracic area, but in the lumbar. And you can probably see there is some probably biomechanical effects of the scoliosis. She'd seen the spinal surgeons who didn't recommend any surgery. And the spinal surgeon she saw was well known to me, and he he would operate on anybody. So if he says no, then it's definitely a no. And I'll come back. So I'm going to talk a little bit about overview chronic pain. I don't want to spend too much time on this, because I think I want to spend more of the focus on the interventions. You can come and chat with me later on if you want to discuss it. A little bit of difference between what we see in children and then possible things for the future. So again, typical pain pathway. Children's pain pathways are different in the sort of pre-adolescence. They tend to start more of a stimulatory pathways. The inhibitory pathways develop later, which seems to be a little bit of a contradiction because children get less chronic pain, so we think. And you can see in animal models that the periaqueductal gray doesn't really start working for analgesia until around the equivalent of pre-adolescence. And same with glia. So we've been quite interested in looking at the work of how glial cells can influence neuropathic pain. This is a staining of glial cells with a sciatic nerve. And if you look at, spinal cord, and if you look at the adults, you can see the increase in activity with a sciatic nerve ligation model. But in younger animals, you don't see it. So there may be an inhibition or a change in activity of glial cells in children compared to adults. And you'll see a bit why that might be important a bit later. Same again, this is an example where circumcised infants, babies, develop an increase in pain sensitivity, which disappears in adolescence. So, as similar to what you see in pediatric and adult practice, the biggest difference is in the sort of different types of conditions we see. We don't see the degenerative back pain. We don't see as much disc herniation, and we certainly don't see as much fell back surgery syndrome. Conditions such as diabetic neuropathy are rare in children. Post-herpetic neuralgia, rare in children. But nevertheless, chronic pain is actually more common than we think. And this is a large study in the Netherlands, about 5,000, seeing about really almost half to a third of the patients experience significant pain. And it's actually across most of the ages. Most of them are affected. And in 8%, they classify it as severe. And yet, in some ways, in clinical practice, we don't see that many children. Most of what we see is adults. So, again, a possible tip of the iceberg, just as in pain medicine years and years ago, before we started recognizing chronic pain, we all thought, oh, it's just pain, it's not a big deal. So maybe something to take a bit more seriously. And here's a systematic review looking at the different particular conditions. And if you look at I've just magnified the part in the box, quite a lot of variations. How can a headache be 8 to 80%? Musculoskeletal pain, you either see hardly any of it or lots and lots of it. So again, this kind of highlights a lot of unknowns because we haven't got good measuring tools, especially with children. How do we measure pain in children? That's another talk, by the way. We can't, the self-reporting scales aren't as effective. We tend to use a lot of behavioral scales, which aren't as valid. But anyway, another thing to focus on, and in some ways to underpin everything else let's talk about pain in children, it's important to look at the context of what they have. Just as we see in adults, we look at, from the last few slides, it's not just pain, it's their suffering. And this is a picture that I took from the Oxford textbook of pediatrics. So if you want these slides, I can give over the slides if you don't want to take pictures. And sensor is the pain experience in the child, but looking at the environmental factors, cognitive behavioral, psychology, social factors, and at the top, behavioral. Now, one thing that I've added to this, which isn't in the book, is the thing at the top, the interventional pain management. Because again, it's not well recognized. Even in the large textbook like this, you won't find a chapter on interventions. Okay, and again, very little in the literature. There are some publications about certain procedures, but this paper here just talks about doing it in the context of a multidisciplinary rehabilitation model, which is absolutely correct. And outcomes are usually short-term. Again, similar to what we do in adult practice, we use the short-term outcomes from doing your injections, your nerve blocks, as a bridge to help the patients get better. A lot of times doing it on their own isn't enough. So these are the common conditions that I see and that we can treat. It's getting bigger and bigger as we see more, as we get more experience of what children's pains are. We're going to see more and more indications, I think. So probably the top one that I do interventions for is for headaches. About sort of 1 in 5 of the children I see in my pain clinic have headaches. And again, the most common cause is migraine. So this is an example of a young girl I saw a couple of years, 3 years ago now. She's now 16, 17. So she presented initially to the neurologists and the pediatric neurologist with left-sided sort of occipital headache. MRI shows Arnold Chiari 1 formation, but again, not really enough for the surgeons to warrant an operation on. And the pain was actually in the left occipital area, the back of her head, but causing a lot of disruption. And again, extensive amounts of investigations, MRI, CT, lumbar puncture. She tried a number of different medications without much success, even going as far as doing indomethacin trial. But again, all negative. So what do we do here? Now, migraine, again, very, very common in children, tends to be more unilateral compared to adults, and it changes phenotype as they get older. So it's something that you bear in mind. A lot of these headaches will improve with age, but in her, she's had it for 2 years without any change. And then she started using painkillers. She was taking tramadol, cocodamol, etc., etc. And a lot of painkillers and a lot of the anti-migraine medications in children are associated with pretty unpleasant side effects, especially at an age where the education is very important and coming towards exams. For example, things like topiramate, propranolol, gabapentin, those side effects are bad enough in adults, but in this age, they're actually much, much more significant. So, is there an alternative? So what we did was an occipital nerve block, and this is a very simple procedure. Most pain specialists are very familiar. It doesn't really require anything particularly unusual skill sets or equipment. And the technique's similar to adults, and you can use ultrasound or landmark technique. And this is the brief overview of the landmark technique. You just feel for the level of the mastoid, neutral line, and use a small needle, and there's about 5 mils of local anesthetic and steroid. So what you want to do is inject and block the branches of the occipital nerves with this. It's very straightforward, and she responded very well. An alternative to this, which I used in her, was ultrasound guided. So you use the ultrasound probe to look at the nerve as it goes above the, and this is superior oblique, okay? And this is what you see. You start at the top of the head. So you start over here, number 1, and then you move down. So number 1 is here, where you see the C1, and you look for what's called C2. And you can see this C2 is bifid, the spinous process, and that's your level where you can do your block. And then you rotate your probe laterally, and you get these 2 muscles here. Okay, this is inferior oblique, and this is semispinalis capitis. And the way you look at this is it looks like the keel of a boat. And you can see here in the overview, if you place the probe in this sort of position, and you can see these 2 muscles. And you can often see the nerve here, and you inject into the nerve. So she did slightly better with the ultrasound-guided procedures. And we did this for a couple of years, which meant that she was able to get through some of her exams and getting her into college. Eventually, we were able to use the transcranial magnetic stimulator. She's moved quite far away now, isn't able to come in. And I didn't really want to use the blocks as a long term. I just wanted to use this as a bridge to see, did the headaches get better with time? Which unfortunately they didn't. But then can we then use it to try something else? And she's very happy using this machine. That's not her, by the way. That's just some random person from the internet. Other options for migraine, you can use supraorbital blocks, and more commonly we're using Botox now. So the same preempt protocol, so it's about 155 units in about 30 different places. Most older children tolerate these actually surprisingly well. A lot of it is about explanation and reassurance. Especially when their headache's quite bad, they will go through this procedure. This is another example, a 14-year-old girl who'd been up and down the country, seen pediatric neurologists and even headache specialists, and she had this pain just over her left temple, despite all the drugs. She even tried the magnetic stimulator machine, which didn't work. So what I did was, for her, I did a mixture of a sphenopalatine ganglion block, and the way I did this was to go for the transnasal. You just get a cotton wool pledget and soak it in 4% lignocaine. And what that does is it just delivers the local anesthetic to the back of the nose to the sphenopalatine ganglion, and you leave it for about 15 minutes. And I also added some Botox to that area, and she's done very well. She comes to see me about twice a year for this. This is a 12-year-old boy who's had, quite unfortunate, he had a cholesteatoma and required mastoid surgery. And he developed quite really severe pain around his ear. And despite medications and even a lot of psychology, he struggled to manage his pain. So what I did for him was 2 blocks. One is an auriculotemporal block, where you just feel just in front of the tragus, around the temporal mandibular joints, and you inject local anesthetic. Because it's close to the artery, don't use any steroid. Just local will do. And the other block I did to get the pinna of the ear and the back of the mastoid was a greater auricular block. And the easiest way to do this is to visualize sternocleidomastoid on ultrasound, and it's just on top of the sternocleidomastoid. And you can see it here, see the arrow, you can see a little nerve, and you can just use a simple 23 gauge needle for it. You don't need anything fancy. So spinal pain. Now, the big difference in spinal pain is that you don't get the degenerative spinal disease in children or the fell back that you get in adults. Most of these are myofascial pains that respond to simple physiotherapy. But when they don't, then I think you can try different things. Again, epidemiological studies shows variation in prevalence, but more than we think. It's about 1 in 6 children supposedly has some sort of back pain. And again, lumbar facet joint injections, it's a different use of it, because in facet joint injections in adults, they tend to be for people with arthropathy and arthritis, where you don't see this in kids. So again, back to this girl, this is what we did for her. We did do injections for lumbar facets, because we thought it may cause some abnormal biomechanics, increasing the pain around those joints. And you can see this is 2013, and 5 years later, there's a slight progression, but not enough for the surgeons to do anything about it. And certainly, her pain wasn't in the thorax, it's actually in the lumbar. So again, the same technique, using spinal needles through the joints themselves. And she did very well. So I see her about once, sometimes twice a year to get these injections done. She came to me really struggling, crutches, wheelchair, and now she's back at school and she's doing her exam. She's 17 now, so I think she's asked me to do some just before her exams this summer, over the Christmas. I don't do many epidural injections, again for reasons because I don't see the same epidemiology. Nevertheless, if you do see a slip disc, it can sometimes be worthwhile. This is coccydynia, so I see a number of children who really have coccyx pain, commonly after a fall. And this is a young lady who we do a little injection to the coccyx. And what I do is I inject behind, and I just push the needle a little bit further through the disc and inject to the anterior. And I actually add in a manipulation. So she's done under quite heavy sedation, so once the injection's done, I just grab the coccyx and just move it in anterior-posterior direction for a few seconds. And again, I just see her about once a year. Okay, overall prognosis is generally quite good after 4 years or so, but then there are still some children and adults who we do see in the long term, and she's likely to be one of them. Now, this is interesting. So we developed quite an interest in renal pain from the adult practice. And we get a small trickle of these children to us. This is a young girl who had glomerulonephritis and was left with quite crippling loin pain on her left side. And again, a lot of conservative management issues didn't help. And what we did was we know from our adult experience that it's a T10 and T11 nerve roots and dorsal root ganglion, which seems to supply a lot of the renal areas. So we place the needle at the DRG, and then we inject with bupivacaine, and then we apply pulse radiofrequency to it for about 10 minutes. And she's a young girl that I see about once, sometimes twice a year, and this keeps her pain under control. She's not on any analgesics. She's just back at school, normal, full-time, etc. Abdominal wall pain, so about 10% of abdominal pain, it's attributed to the abdominal wall itself. And certainly, these are quite easy and safe injections to do. So this was one of the first girls I saw when I started my pediatric practice. She was referred to me because, she's been under a number of different specialities. She had appendicitis. It wasn't clear whether it was appendicitis or not. She began with the lower quadrant pain, went to see gynae, had ultrasound laparoscopies, and eventually was under a psychiatrist. So the mum found out where I was and asked me to see her. So I did a couple of options. One, I chose an aloinguinal block, and we did this bilaterally, so she's got bilateral lower abdominal pain. And again, this is easily done with ultrasound. So you look for the 3 layers, and the trick about the aloinguinal block is that the biggest layer is the internal oblique. And these are where to place the probe. And sometimes you can see the nerves, but really what you're aiming for is actually inject about 10 mils of local anesthetic steroid between these planes. And you can do the same again with the rectus sheath. This is more useful for people with central abdominal pain, especially if they've had multiple surgeries. And what you do is you look for the rectus abdominis and you just inject underneath that muscle. Okay? Don't go there, that's the peritoneum. And after, I only did a single block for her, and she sent me a thank you 3 years later, and she's still good. Not that common to see that, but again, this is where it becomes quite useful. So neuropathic pain, I'm going to touch a little bit about neuropathic pain. This is something that I don't see as often. And the main difference in children is that they don't seem to suffer as much when they're younger. For example, post-thoracotomy, the incidence increases with age. Same again with phantom limb pain. So phantom limb pain, we don't see as much in children as in adults. So we see some of the patients that have had amputation from cancer, very rarely traumatic. I've got one 4-year-old boy who has the traumatic amputation of his arm, but interestingly, he doesn't have any phantom sensations. Most of the time, it's stump pain. And again, common to see in the initial perioperative, but it does get better with time. So most of these children don't need interventions. A lot of them respond well to rehabilitation. Interestingly, just as a side, obstetric brachial plexus injuries. We've all seen the adults who've come off motorbikes, had traumatic amputations, and it's common to see them have quite severe neuropathic pain. Well, it's rare in children. This is an obstetric injury, and it's hardly recognized. We just don't see it. And again, it might come back to what we had before with the slide showing differences in pain mechanisms and glial cells. That may be a possible mechanism of why they don't get the pain. Could be because in some ways, as they get older, they get a lot of adaptation and they just get adapted to it. So same with spinal cord injury. Again, when you're younger, you don't get as much pain. CRPS. So we see a number of CRPS patients in our unit. And the main difference in adults is that they tend to be much more female and they tend to be more lower limb. And again, this is from the latest guidelines from the UK. You talk about psychology, education, physical therapies. And interestingly, there's still a big quarter goes to pain relief. And this is often neglected, really, for CRPS. Mostly because by the time they've got to us, they've done it all up. And for the CRPS patients, we can do a short brachial plexus catheter. For the lower limbs, you can do sympathetic or an epidural catheter. But the problem about the lower limbs is that you don't want too much motor block. Now, this is usually reserved for the refractory ones. And the important thing is this is to facilitate rehabilitation. It's not a treatment on its own. Do not do this without the guidance of the multidisciplinary team. Because one of the things is the prognosis for CRPS in children is excellent. 90% improve after a year. They do relapse. So after a few years, they sometimes relapse, but what you do is you institute the same intensive therapies, and they go back to being good. Neuromodulation, I'm not going to touch too much on this, but because it's something that in the past we hadn't been able to do in children because of the requirement for intraoperative wake-up and MRI. But what's interesting is that my colleague over at the Evelina, who does deep brain stimulation dystonia, has had some very surprising results in that he's noticed that they get some pain relief, which is independent on the effects on the motor system. So the paper's not been published yet, but watch this space. Again, neuromodulation, something perhaps for the future. The difficulty again is MRI, which has now been overcome. It needs intraoperative waking, which has now been overcome. Now we just need to find reasons to do it. So to conclude, interventions for children, a niche topic. Sometimes you have to really think why you want to do it. And you have to do it in the context of the multidisciplinary rehabilitation process. It's not something to do on its own. And in some ways, that's the same as an adult practice, really. not much evidence. We're not really going to find randomized trials. It's going to be mostly case reports. But certainly something to think about, especially when the rehabilitation and all the other treatments have been unsuccessful. Okay, thank you very much.